So antimicrobial stewardship, page 171. Those who have the textbook, page 171. So antibiotic resistance, that is abuse and overuse of antibiotics, have led to a situation in which it's difficult to recover from bacterial infections because the bacteria is not responding to any antibiotics. Okay, especially the class 1 antibiotics. So globally, we see a failure to address this problem of antibiotic resistance. It could result in 10 million deaths by 2050. Okay, and this could cost around $66 trillion pounds in for the healthcare system. Okay, to overcome this. So antimicrobial policy, for that you should follow an annual antibiogram. Okay, that should be prepared by the microbiology department, and it can be shared across the region. Okay, one microbiology department, a regional microbiology department, can make it and share across the hospitals in that region. Okay. So antibiotic susceptibility profile, that could be analyzed regularly. And common resistant patterns of certain bacterial isolates can be studied. It can be reported in the healthcare infection control, hospital infection control meetings, committee meetings. And this policy should be prepared in consultation with clinical departments as well. Okay. So this is an antibiogram. So a patient sample is taken where you doubt that the patient may have antibiotic resistance. Okay, or even without that, you take the sample, you find out the culture of the bacteria that is infecting this patient. Okay, and once you find out which kind of bacteria have been infecting the patient, that's the standard tables for if it is the bacteria XYZ, this particular antibiotic has to be used of this particular class. Okay, class 1, class 2, class 3, like that. There are different classes of antibiotics. Okay, for specific bacteria specific antibiotics has to be used. Do not abuse that antibiogram. Okay, antibiogram comes with a list of bacteria's names, and adjacent to that, what exact antibiotic has to be used to overcome this bacterial infection. Okay, that you have to precisely follow. That is the importance of antibiogram. Okay. So antibiotic policies and principle. Data is analyzed on a quarterly basis as per hospital records. And this data, it usually consists of how many patients are undergoing antibiotic resistance, what is the common site of infection of this antibiotic resistant bacteria, which age group is usually affected by this, and is it an OPD patient or clinical patient or in ward patient. Okay, inpatient departments, ICU, from which ward we are getting the majority of the antibiotic resistant cases. Okay, so these data has to be analyzed on a quarterly basis, once in 4 months. Then standard treatment guidelines are also made as per age. Okay, and also as per community associated infection and healthcare associated infection. Okay, what standard protocols or medicines or procedures that you use for a 5-year-old could be different from a 65-year-old. Okay, the procedures or the medicine doses, frequencies, okay, that is used for in an NICU would be different from what you do in an inpatient ward. Okay, so every based on the patient's age, which type of infection, okay, which kind of ward, site of infection. Based on all these different areas, standard treatment guidelines are prepared and you have to follow that. Okay. Then classification of antibiotics into first line, second line, and reserve group of drugs. Okay, first line and second line of antibiotics are commonly used. Reserve groups of drugs should not be abused. It is kept only in situations where it has been diagnosed that the person is suffering from antibiotic resistance. In that case, reserve group of drugs of antibiotics are used. Otherwise, first line, second line, like amoxicillin, ciprofloxacin. Okay, these are the antibiotics which come under the first line, second line category. Okay. Then what you have is prescription auditing. So this auditing is done for the doctors who write the prescription, okay, for the pharmacy, for the medicines. That is prescription auditing, just to see that why the doctor has prescribed antibiotics. Is there a proper rationale to it? Okay. And also they will check the pharmacies. Are they giving antibiotics as per what has been prescribed or are they giving something else? So those all uh, validations come from prescription auditing. Okay. You review on a regular basis, you will review antibiograms, and based on the antibiograms are the prescription being done, and based on the prescriptions are the medicines being distributed. Okay, so these are the different levels of prescription auditing. Education and training for all infection control activities in collaboration with Hospital Infection Control Committee. So continuously training, even if you have given a training program of antibiotic resistance to the nurses or the healthcare workers, doesn't mean that it has not, it should not be continued. Okay, you can repeatedly train the same set of healthcare workers on the same topic. Okay, it's more like revision. Okay. Then measures to control the spread of antibiotic resistance. Each healthcare facility should have an antibiotic use program. And the goal here is to ensure effective economic prescribing to minimize the selection of resistance organization or microorganisms. And also, this is a multidisciplinary approach. Antibiotic resistance is not just the responsibility of the microbiology department or the doctors or the nurses. Okay, it is a multidisciplinary approach. Okay, hospital healthcare workers from different departments should come together to make sure that antibiotic policies, antibiotic stewardship is being respected. It is being followed. Okay, the use of antibiotics should be justifiable. Okay. And also do the cyclical rotation of antibiotics, but not class rotation. Okay, that is also a measure to control. For example, class 1 antibiotics may have 5 to 6 types of antibiotics. Okay, if one antibiotic does not work, you want to use a different type of antibiotic. Stay within the class, don't jump the class. Okay, if a particular type of antibiotic in class 1 is not working, does not mean you will jump directly to class 3 or class 4. Do not jump to higher range of antibiotics. Stay within the class and start with a new type of antibiotic, but which is within the class. Okay. Then standard and contact precautions should be followed, adhering to the hand hygiene, using personal protective equipments. This is for the healthcare workers. It has to be followed. Isolation and cohorting the patient whenever it is required. Training and education of healthcare workers, cleaning the environment, ensuring the environment is clean, patient dedicated equipments should be used, equipments and general patient equipments, categorize them. Sterilization and infection should be properly done. Surveillance should be done for each and every antibiotic resistance cases that have come up. Then methicillin resistant Staphylococcus aureus, MRSA. This is also an antibiotic resistance. So here the MRSA strains, they are resistant to penicillin. Penicillin does not work here. Okay, methicillin, penicillin will not work here. Vancomycin may work. Teicoplanin may work. Okay, but penicillins don't work for MRSA infections. Okay, they are very highly transmittable. Even across the hospitals, they can spread. If one patient has MRSA, they can spread MRSA to the entire hospital as well. Then control measures, screen all the patients for MRSA carriage, especially when you see the signs and symptoms like spider-like bites on the body, okay? Purulent discharge from the spider-like bites on the body, redness, lethargy. If you see these kind of signs and symptoms in a patient, immediately screen them. Are they a MRSA carrier or are they suffering from MRSA? Okay, then according to that, you have to isolate the patient, cohort them, or isolate the patient. Then standard and contact precautions has to be followed by the healthcare workers so that they don't spread it among themselves or among between different patients. Then isolation ward, if it is available, should be put into isolation ward or the isolation IC should be used. And if you have more than 2 cases of MRSA, then you can cohort the patients together. All the MRSA patients can be kept together in a single ward. Treatment of infected patients. MRSA treatment with vancomycin, teicoplanin, that those are the first choice of drugs for MRSA cases. So treatment will be started. Then environmental cleaning. Environmental cleaning, horizontal cleaning should be done on a regular basis. Vertical cleaning can be done in once a month or once a week, but horizontal surfaces has to be cleaned on a daily basis. Education and training of staff. Again, repeated training have to be done. Staff should know how to tackle a MRSA situation. So this can be a MRSA screening on arrival. If there is a high risk patient, like a patient who was in ICU for a very long time, okay, that's a high risk patient. So expert MRSA culture screening can be done. Expert is a brand, okay, of the kit. that we use to do the MRSA screening. There are other brands available as well. Okay, and if the patient has turned out to be MRSA positive, isolate them. If the patient is MRSA negative, isolation is not required. Directly, you can admit the patient into wards. And if it is a non-high risk patient, but they could be a carrier, okay? So culture screening has to be done, or like any swab, blood culture, urine culture screening has to be done. If they are positive, again isolation. All MRSA positive cases will go into isolation, and if it is negative, no action required. They can be admitted in regular wards. Then vancomycin resistant enterococcus infection. Difficult to treat because a lot of intrinsic resistance is there to this antibiotic agents. Okay, this strand of bacteria is very much resistant to a lot of antibiotics. And control methods. So control methods for VRE. Judicious use of antibiotics only and only if it is required. Go for higher classes of antibiotics. Otherwise, do not touch that. Okay, consider that those antibiotics as reserved group of drugs. Education of healthcare workers in terms of how to treat the VRE infections, what protocols has to be followed, standard precautions, transmission-based precautions. Usually contact precautions is used here in VRE. Hospital infection control practices involve screening, isolation, equipment and environmental cleaning has to be done in the wards where VRE cases are there. And do not put VRE or MRSA cases with other patients. Do not mix VRE cases with other patients because they should have a separate washroom or a toilet. Single-use equipments are used since it is a contact-based infection. Transmission is contact-based. Then isolation. If isolation wards are available, isolate the patient. Otherwise, isolation bed in ICU can be used. And if you have more than 2-3 patients of VRE strand, and then you can cohort the patients together. But isolation is the first choice. Okay. Use PPE, personal protective equipments, especially contact precautions has to be used here. Surveillance has to be done. Record each and every case of VRE, and it has to be checked why it happened, how it happened. Okay. How it has been spread. Then you have multi-drug resistant gram-negative bacteria. So to find out this situation, screening is very important. All the patients who are high risk, okay, uh, for example, patients who have been on broad spectrum antibiotics for a very long time. They are in a hospital for a very long time. Severely ill, chronic disease patients, okay, uh, and patients who have invasive medical devices on them from a very long time. Okay, so these all are the high risk patients. So you have to definitely screen them. Screen swabs of multiple site from multiple sites, not just the nostrils. Throat swab should be used to send it to the laboratory. Follow stringent and hand hygiene contact precautions, isolation precautions, cleaning. Patient equipment should be dedicated. Do not mix it with other patients. And judicious use of antibiotics. Judicious use means prescribe only what is required and necessary. So in healthcare facilities, um, the spread of antibiotic resistant infection, it's usually the broad spectrum antibiotics uh, resistance that is seen in healthcare facilities. There is a there are high for some classes of drugs unexplained variation between hospitals in use of certain antibiotics. Okay, it was not required to prescribe, but still prescription was given. So that is an unexplained reason. Why was the prescription given? It was not required. The patient may or may not be suffering from bacterial infection, but why antibiotic was prescribed? Okay, so these are the areas in which, when the healthcare falters, it leads to multi-drug resistant infections and all. In the community, we don't have a very strict surveillance system to control the narrative in community. Okay, if you go to any pharmacy, okay, and you ask for an antibiotic, they will give you without any prescription. Okay, so that is how in community, at a community level, you see these challenging situations of multi-drug resistant infections. Antibiotic treatment for hospitals. If you follow the stewardship, okay, if you reduce the prescription of antibiotics in hospitals by 30%, okay, then there could be very few cases of deadly diarrheal infections. Okay, it is a direct relation. If you reduce high risk antibiotic prescriptions by 30% in the hospital, there are chances that you are reducing the uh, diarrheal infection as well, which is multi-drug resistant. Okay. So, what is antibiotic stewardship? It's a promise, it's an effort that you take to measure and improve how antibiotics are prescribed by the clinicians or used by the patients. That is what CDC has given. Okay, Center of Disease Control. CDC has given this definition. What is antibiotic stewardship? It is an effort that individual takes, okay, to improve how antibiotics are prescribed and also how it is used by the patients, because you may be prescribing the correct amount, the correct frequency, correct dosage and all, and also you are prescribing the correct type of antibiotics, but still the patients are not following the doctor's orders. Okay, that could lead to, again, multi-drug resistant situations. Next, it aims to optimize the antimicrobial use among patients in order to reduce the resistance, improve patient outcome and safety, and also ensure that the treatment is cost effective. Because the higher class, if you're jumping in terms of antibiotics, the more higher class you're prescribing, it comes with a cost. Okay. So to keep the treatment cost effective, to ensure that it is the prescription is safe for the patients, and also the outcome is good from the patients, the prognosis is good. Okay, so that is also the objective of this stewardship. At healthcare facility, antibiotic stewardship involves implementing an antibiotic stewardship program. You have to make sure that all the healthcare workers know what is antibiotic stewardship and they take the oath of following the rules and regulations. Continuously monitoring and analysis. Okay, how antibiotics are being prescribed, how it is being used, how it is being used in diagnosis, treatment, and all. Then these all are the subcategories that come under antibiotic stewardship. Okay, so when you follow antibiotic stewardship, all these subcategories get enhanced. Okay, they function cohesively with each other. Okay, so your infection control and prevention becomes enhanced. Okay, you will not try to falter there. And controlling the source of infection. If there is a chain of infection, an outbreak that has happened, you will control that. Okay, prescribing antibiotics which are truly needed. Only what is required and only what is needed. Only that class of antibiotic will be prescribed. Prescribing appropriate antibiotics with adequate dosages as well. Using the shortest duration of antibiotics based on evidence. Because if a bacterial infection can be taken care within 3 days of continuous administration of antibiotic, stop it at 3 days. You don't have to drag it to 5 days or 7 days. Okay, keep the antibiotic uh, treatment short, simple. Okay. Reassessing the treatment when culture results are available, because sometimes you may have to change the antibiotics. The antibiotics that you're giving is taking care of a particular strain of bacteria, but it may not be working on another strain of bacteria which has also infected the patient. Okay, so once you get the second list of results from the laboratory, you have to reanalyze your antibiotic choice. You may have been giving amoxicillin, which was working fine. It took care of majority of the infectious strains. Some are remaining. Okay, so whatever strains are remaining on which amoxicillin didn't work, maybe ciprofloxacin can work. Okay, so you may have to make a switch there. Support the surveillance of antimicrobial resistance and hospital acquired infection. Each and every case has to be recorded, how it happened. Okay, what was the strain, how it happened, how it was controlled. These things have to be recorded. Educating the staff continuously, and also supporting an interdisciplinary approach. Not It is not the headache of just one department, like the clinical laboratory. No, the doctors, nurses, pharmacists, okay, infection control committee, they all are involved in making sure that the antibiotic stewardship has been followed. Okay, so that's about antibiotic stewardship.